Good afternoon, everyone, and thank you to the POTS Foundation for inviting me here today to speak. I'm Fraser Burling, I'm from New Zealand, and I have conflicts of interest. I work in a single centre from which I receive consultation fees. I receive no drug funded for any of the drugs that are presented. Sorry? And I have over 900 patients with EDS, so I have a bias in wanting them to get the best care possible. Presentation layout is going to be broken up into 5 points. Firstly, the introduction to Ehlers-Danlos Syndrome, which is a whirlwind introduction, syndromic aspects of hypermobility, and complications associated with EDS dysautonomia, then treatment options, and finishing off with 3 examples if we have time. So, why the zebra? If you look closely at this photo, you'll see actually what look like horses, zebras, and you're seeing the shadow as the horses. The zebra is the mascot for Ehlers-Danlos Syndrome. If you hear galloping hooves, don't automatically think horses. Sometimes they're zebras. And also, no 2 people with EDS are the same, and no zebra has the same stripes. And that's even people with genetically identical pathways, so identical twins can be completely different in their presentation. These 2 references here are the main references throughout my presentation, unless stated otherwise. So the first is the American Journal of Medical Genetics, Part C, March 2017. That's the New York criteria. And then the 2021 update, which was December 2021. So unless otherwise referenced, these articles are the sources. They are available online, open source, free of charge. So what is hypermobility? Most of us know the Baton score, which is widely used and accepted. Just to go over it, the little finger going back 90 degrees, you'll see I'm not hypermobile. If you have uncertainty, put the hand on a flat surface and bring it back, because if it goes back to 90 degrees on a flat surface, then it's positive. Thumb to the wrist, a little gentle pressure may be needed in some people, but that's all that's needed. You don't need to push hard. Elbows greater than 10 degrees extension. As you can see, I don't even reach 180 degrees. But the palm up. With the legs, it's getting them to push their legs back. And if that's not obvious, then you lie them down on the bed and gently raise the leg. And bending over with the knees straight, not shown in point 5 here, but with the knees straight and palms flat to the floor. This is a study of 1,000 people that was done in Australia and published in 2017, looking at hypermobility in the general population. And as you'll see, if you look closely at it, females are more hypermobile than males in general, and hypermobility drops off with age. So under 3, you can't diagnose hypermobility because all children under 3 are hypermobile. Between 3 and 6, the hypermobility drops off, and by the time you reach 6, it's usually, then you can tell quite clearly whether someone is hypermobile or not. However, there are adjustments when we look at the New York criteria according to age, which you'll see shortly. So firstly, we have the 5-part hypermobility questionnaire, which is also known as the HACM score by Alan Hakim. He, and with a number of colleagues, looked at the prevalence of hypermobility and looked at these questions. And if you've got 2 or more of these questions positive, then there's a good chance you're hypermobile, with 80% sensitivity and specificity. So you'll see a couple of these are related to the Baton score. Can you now, or could you ever, place your hands flat to the floor without bending your knees? Can you now, or could you ever, bend your thumb to touch your forearm? As a child, did you amuse your friends by doing contortions such as putting your foot behind your head or doing the prayer hands behind the back? As a child or teenager, did you dislocate a shoulder or a kneecap on more than one occasion? And do you consider yourself double jointed? And many people do party tricks with their fingers of how they're double jointed. Hypermobility is a syndrome. It is a spectrum. It doesn't have hard and fast endpoints and beginning points. It starts with regional joint hypermobility, that goes to generalized joint hypermobility, And as they are not syndromic, they are not part of Ehlers-Danlos Syndrome. Once you start getting the syndromic aspects, then you are part of the EDS. So that's where you have hypermobile spectrum, then hypermobile EDS, and then the areas where we have known genetics for the other 12 types. So this is the 27 criteria for hypermobile EDS, and distinguishes hypermobile spectrum disorder from hypermobile EDS. First part 1, is the Baton score, and you'll note that children need 6 or more on the Baton score. Once you're a teenager through to 50, you need 5 or more, and over 50 it's only 4 or more. But this is where the importance of history comes into play from the Hakim questionnaire. Because people can have a Baton score of 5 at the age of 45, and by the age of 50, the Baton score is 0. And so the Baton score does drop with age. And so that is, the history is just as important. If you've got a 7-year-old though, and the Baton score is only 2, they're not hypermobile. The history is not relevant. So the history of being hypermobile as a child is relevant to adults, not to children. Part 2, 2A, is the most difficult part when you're assessing patients. You need 5 or more on 2A for the 2A to be positive for the hypermobile EDS as opposed to hypermobile spectrum. And going through the list, the soft velvety skin is very common. The mild skin hyperextensibility, not quite sufficient for the classical phenotype, which is 3 centimeters in the neck, 3 in the elbow, 3 in the knee, 1.5 from the back of the wrist, and 1 from the palm. You can measure those with a clear ruler so it sees easily. Unexplained stretch marks. So in particular, stretch marks on the back is quite sensitive for EDS. Hips and thighs you might get in someone who's overweight, but the back is really quite sensitive. However, if you've got a slim person and they've got stretch marks on the hips and thighs, that's still relevant. When it comes to atrophic scarring, you don't need to have the 2 centimeters of scarring that you see in the classical phenotype of Col5A1, which is really papyraceous scarring, i.e. it looks like paper thin or cigarette paper. But even a 0.5 centimeter of skin stretch, when scars are normally fine white scars, if you've got a 0.5 centimeter, that's relevant to those who are hypermobile. For the marfanoid habitus, so 0.9, the arachnodactyly, that's associated with, so you've got the Walker sign, putting the hand around the wrist. If the thumb and little finger overlap, that's positive. And the Steinberg sign, when you're putting the thumb through the hand, if it comes out past the side of the palm, that's positive. If someone has both arachnodactyly and an arm span greater than 1.05 ratio against their height, you really must have Marfan's in your differential and be looking for Marfan's as well. Points 11 and 12, they're almost never seen. If they're seen in a child, that's a major red flag for something else going on. In adults, it occasionally happens, and that can happen as people get older. Now, the thing about the hypermobile spectrum and the fact that it is a spectrum is that people can move from the left to the right. So someone with hypermobile spectrum disorder can move into hypermobile EDS as they get older, and we see this happen over time. So while the hypermobility drops, the other factors become more. Part B is a family history of someone who has at least 5 or more for the hypermobile EDS present within them from Part A. And Part C, of course, is musculoskeletal, which it's very easy to find in people with EDS having those issues. Criteria 3 really is ruling out all the other more serious things that might be causing this, not just other types of EDS, but other connective tissue disorders such as Ehlers-Danlos Syndrome and Stickler syndrome, osteogenesis imperfecta, etc. How common is hypermobility? So depending on which study you look at, it can range from 2% to more than 50%, but it really is population dependent. It's generally considered 1 in 50 on a worldwide basis. People with Asian origins tend to have a higher amount of hypermobility. But that doesn't mean they have EDS, they're just hypermobile. Compare that to vascular EDS, where it's 1 in 75,000 to 1 in 150,000. That's your Col3A1 patients. You can get vascular-like with Col5A1, Col5A2, Col1A1, and Col2A1 as well. But the Pure vascular is the COL3A1. For hypermobile EDS, it's considered to be 1 in 500. So 1 in 10 people who are hypermobile have a syndromic aspect, i.e. have Ehlers-Danlos Syndrome. So hypermobility does not equal EDS. And as mentioned, hypermobility does reduce with age. The syndromic aspects. So firstly, EDS doesn't cause injury. Accidents cause injury, but you're more easily injured if you have an accident. I repeat that, you are more easily injured if you have an accident. In New Zealand, we have an ACC who try to say EDS caused the injury. No, actually, an accident caused the injury. They weren't in pain prior to the accident, even though they had EDS the whole lifetime. And we have patients with no pain who still have EDS. But you are more easily injured, and it is harder for the injuries to heal. And therefore, you need more gentle physiotherapy, more gentle osteopathy, more gentle allied health input, podiatry, etc. You need more gentle recovery from surgery. You need more careful closure of wounds with sutures in multiple layers. And the stitches often need to stay in longer. Dysautonomia in EDS. This is the POTS conference. Dysautonomia is common. POTS is one of the issues, but as you heard this morning, POTS isn't the only factor in dysautonomia. And patients with EDS have low blood pressure. Can be from POTS, can be from orthostatic hypotension, can be from other causes. As you saw this morning, they have low circulating blood pressure because when they stand up, the blood vessels open. When you've got abnormal collagen, the blood vessels relax more when you're standing up and it pulls in your legs. You've got the effective blood volume coming up to here, and above here you've got low circulation. This causes an increase in circulating catecholamines like adrenaline, which then causes you tachycardia, which then feeds back producing more adrenaline, and then aggravates your POTS further. Medications that are used for pain relief, like tricyclic antidepressants, can aggravate the dysautonomia and the POTS. When you've got mast cell activation issues, autoimmunity problems, antibodies directed against other receptors, they can again regulate heart rate and blood pressure and other autonomic functions. Excess systemic histamine. Histamine also dilates blood vessels. And rarely you've got the brainstem issues, such as Chiari malformation and craniocervical instability, which is not that uncommon in EDS. All you have to do is ask the right questions to find it. Triggers. Most of these have been covered this morning, so I'm just going to cover a couple briefly. Dehydration, warm environments. Australia's a lot warmer than New Zealand. The Valsalva maneuver, which isn't just straining when you're, to help your heart and lungs, but it happens when you're going to the toilet and passing a bowel motion. It happens when you're lifting a heavy object. And when you relax from that, your blood pressure drops. Alcohol dehydrates both by opening up the blood vessels and increasing urine production, and caffeine increases urine production. Having a large meal, the blood rushes to the stomach afterwards. Great for snoozing after lunch. I hope I don't put you to sleep. Can also happen during infections. Septic shock, of course, is the extreme end, but people with EDS have more drop in blood pressure from even milder infections, even things like COVID. Stressful situations, even a blood test. People without EDS can still faint when seeing blood. People with EDS are higher probability. Having an argument, your face becomes suffused if you're angry, and then after that it relaxes and the blood pressure drops. Doing exams can also drop your blood pressure and stress response. Painful stimuli. When you get a severe pain, you produce adrenaline for the fight-flight reaction. If you're neither running nor fighting, the blood pools in your legs. Your blood pressure drops. High altitude drops the blood pressure as well. Long periods of rest, that includes loss of muscle tone from inactivity over a period of time. And if you've been in chronic pain for a period of time, you're going to drop your blood pressure when you try to stand up because your muscle tone has dropped. Surgery, obviously, again, you have periods after surgery when you're inactive. Even 3 days of inactivity can cause a significant drop in muscle tone. And then allergic reactions. So, touching on the syndromes. People with EDS metabolize drugs differently. Anesthetics is a great example. How many times someone goes to the dentist who has EDS and they need 2 to 3 times the dose of anesthetic? 2 to 3 times the dose of anesthetic. They're a higher risk of waking up under a general anesthetic. They actually break down anesthetic a lot faster than normal. And it's not just anesthetics as well, it can be other drugs, sedatives, etc. They bleed more easily. Now, desmopressin, DDAVP, is noted in the 2017 publication to reduce the risk of a major bleed in surgery from 30% to 0%. It's very helpful. The one thing is, firstly, just a single squirt pre-surgery is all that's needed. But please check the sodium levels within 24 hours afterwards because it can drop the sodium levels and cause significant hyponatremia. It's easy to treat that with an infusion of saline, and a infusion of saline is much less risk than a blood transfusion. Vitamin C reduces bleeding risk overall. Why? You need vitamin C to produce collagen in at least 5 different aspects of collagen synthesis. You've all heard of scurvy. It still happens in this day and age. So the international criteria recommends 2 grams a day of vitamin C as a minimum. If someone's got vascular EDS, we tend to go up to 4 grams a day. Again, increased risk for dysautonomia, we've covered POTS. Supraventricular tachycardia, so people can have their heart race even when they're lying down. These people still benefit from beta blockade and other medications to slow the heart rate down, ivabradine, midodrine. Orthostatic hypotension without the racing heart is also very common. Stand up, the blood pressure drops, but the heart's not necessarily racing. Sports tights are really helpful. Compression stockings, while they're as effective, aren't effective because people don't like to wear things that are not fashionable. And they're much harder to get on. Sports tights often have nice zippers that are also protected from your skin when being done up, and so they're much more commonly worn. They also don't roll down the way that compression stockings can and cause a tourniquet effect. So sports tights tend to be much more fashionable, easy to put on, easy to take off. I'm not going to cover medications too much. The next talk's going to cover that very well. As you heard this morning, there is a significant increased risk of migraine in people with EDS, and that has multiple reasons, of which only a couple were touched on earlier, and I'll touch on a bit more later. But also, actually fainting from the dysautonomia is more common. Temperature dysthermia, this is actually a type of dysautonomia. They often feel hot on cold days and cold on hot days. I see many people nodding their heads. It's common. They can also, I have a few patients who have temperature swings from 35 degrees to 38 degrees. They don't have a familial fever syndrome. They have this temperature dysthermia issue. And the New York criteria 2017 noted the temperature dysthermia issues, but treatments for this have not been studied, and so far we don't have a good way of treating this yet, other than altering the number of layers of clothing you have on at the time. Gastric issues. As you've heard this morning, there is a marked increased risk of gastric issues, but this also happens in people with EDS. Gastroparesis is not that uncommon. Probably 5% of my patients have some degree of gastroparesis. Some of them need to have nasojejunal feeding or percutaneous jejunostomy feeding, and a few need intravenous feeding. Many get away with just blended foods, soups and smoothies, because then the stomach doesn't have to do the work. One of the first signs is someone having a meal 8 hours later, vomiting up their food, and often what comes up looking exactly like it went down was steak. It's really hard for the gut to break down steak when you've got the stomach not working properly. Small bowel dysmotility, again, you've heard about that this morning with slow ability of food to go through the gut slowly. Large bowel is the same. We have patients who go 6 weeks between bowel motions. Conversely, we have patients who have 6 bowel motions a day with diarrhea. And then we have people who fluctuate between the two, so you get the IBD-like symptoms coming through. And then this next one, avoidant restrictive food intake disorder, or ARFID syndrome, has multiple causes. So if you've got gut dysmotility, it can be painful. If you've got a distended gut, it can be painful. If you've got mast cell activation syndrome and 20 minutes after eating, your gut flares into pain from that, people don't want to eat their food then. It's not anorexia. It's not bulimia. It's often confused as such, but it is not anorexia or bulimia. It's ARFID syndrome. And then I've been recently made aware of the vascular compression syndromes. A whole paper is allocated to this in the 2021 publication with a couple of patients who have median arcuate ligament syndrome, superior mesenteric artery syndrome, May-Turner and Nutcracker. And this is where the visceropter, so the organs moving southward, you've also got ligaments that move southward and start to cover parts of the gut and parts of your arteries. And that is extremely painful. If it's covering part of the gut, you try to push food through this when you've got this tight band overlying it, it's not going to work very well. It's very painful. Currently, I understand Adelaide has actually been moving forward in this area, and there's someone who's treating those here. Otherwise, people have to go to Germany. Certainly New Zealanders have had to go to Germany recently for that. But I understand Adelaide is actually coming ahead for Australia, so good on you. Bladder and uterus. When I have a patient in front of me, I say, have problems with being a frequent flyer or a retainer? People can hold on to the urine all day long and not have to go to the toilet. Wonderful when you're going out and about. Not so good for your bladder. If it's left distended too long, you can end up needing to self-catheterize or worse, having a suprapubic catheter. So I tell them, please make sure you pass urine at least 3 times a day. For the frequent flyers, they feel like they've got a urinary tract infection, but don't actually have one. Or they may have problems with the prolapses in the pelvis. But those with mast cell activation, which you heard about earlier, you treat their urine frequency by giving them an antihistamine, and suddenly the symptoms vanish. So treating mast cell can make a big difference to those who have dysuria symptoms or urine frequency. Pregnancy, apart from the COL3A1 where there's a risk of rupture of the uterus, at the time of delivery, you can be slippery fast or complicated. It's actually really rare to have women take between 8 hours and 24 hours to pass the fetus or deliver the baby. Some deliver within an hour. I had one who delivered within 7 minutes. Conversely, if you reach 24 hours, you really need to be putting knife to skin for the cesarean, because 24 hours is usually the cutoff for cesarean. If you don't do that, the longer you go, the greater the risk for prolapses. And the risk rises exponentially with that time after 24 hours. So, hypersensitivity and mast cell activation. Larry covered this very well. There's only a couple of things I'm going to mention in here on this list. Endometriosis. 5 times more common in EDS than non-EDS people. When you've got a period happening and you've got lax tissue, the myometrial and endometrial tissue can go up through the fallopian tube into the abdominal cavity. And I believe that's the main reason why endometriosis is much more common in women than with EDS than without EDS. Celiac is 10 times more common in EDS than non-EDS. And if you take 100 people with celiac, 1/3 of them will be hypermobile. Again, that's well published. And drug allergies are far more common. At least 2/3 of my patients have major drug allergies. Mast cell activation is present in 2/3 of people with EDS. Gastric issues are present in 2/3 of people with EDS. Dysautonomia and POTS are present within 2/3 of people with EDS. Not all the same 2/3. Psychological. Psychological issues are common in EDS, but not commonly recognized, and they are commonly secondary. The risk of primary psychological issues is no greater than the general population. The risk of secondary issues is much more common. Anxiety, whether it be from the POTS, whether it be from the gut issues, or worst of all, whether it be from not being heard by doctors. That's far too common. Depression. Most people with EDS will have had some injuries. Pain is a major depressant. Get rid of the pain, the depression lifts. I've seen that time and again in my clinic. Get rid of the pain, the depression lifts. Primary depression is no more common than the general population. Post-traumatic stress disorder. Again, people with EDS are more commonly injured, but unfortunately the most common reason for PTSD I've seen in my patients is doctor-induced. And it's frustrating, but we're hoping education like this can make a difference so that people realize they're being heard, being understood. ADD and ADHD, the 2021 publication noted this is 5 times more common in EDS than non-EDS people. Autism spectrum, 5 times more common in EDS than non-EDS people, same publication. Delayed physical development is common. It's not mental. They don't have a decreased intelligence. It's the physical aspects that are affected because it's their connective tissue that's affected. So they have slower ability to starting walking. Many will bum shuffle before they can walk. You may see this in some people. They often have disorders at birth within their feet, and our podiatrists will see that. Slower to catch a ball, slower to write. If your finger's hyperextending backwards, it's actually hard to write with a 2-finger pincer. They'll often use a 4 or 5 finger motion to write. Overlaid ring splints can make a huge difference to the ability to write. Decreased position sensation and proprioception is common. Walking down a hallway and walking into the wall. Aiming for the center of a doorway and hitting the doorpost. It happens, and it happens commonly. Put them into clothing which touches their skin, and they walk straight through the doorway again, just giving them for that 1 extra point of position sensation. Some people, the collective noun for zebras is a dazzle of zebras. So POTS treatments in EDS, we know avoiding and reducing exposure to many of the triggering factors. Withdrawing medications that might worsen symptoms is a little bit harder. If you're on your tricyclic antidepressant for pain, then it's harder to take that out to treat the POTS. Sometimes you have to walk a little bit of a tightrope between benefits versus risk when you're treating these people. Maintaining good hydration and balance is important. Extra salt and fluid. I've got my little recipe there for homemade sports drinks for those who can't afford the bought ones. We have some wonderful bought ones you can buy here, but the homemade one is for those who are too poor to buy those. Reducing the venous pooling in the lower limbs by elevating the legs. Whenever you sit down, put your feet up. But also the compression garments and sports tights, as we mentioned. Exercise, small amounts often. You try to do a large amount at once and they'll crash and burn the next day, and then there's 3 days before they can do it again, and then they actually end up losing tone because of they're having more days out of action than in action. Sometimes you need to just do 1 or 2 minutes an hour. Taking a minute each hour that you're awake to get up and do something makes a huge difference to your quality of life and building your stamina back up again. And then dealing with the hypermobility, instability, and injury so that people can exercise again. It's really hard to exercise when you're in pain. That's a whole nother talk in its own right. So physio, importance of being gentle. Now, people with, who don't have EDS, the muscles are lax, the ligaments are tight. People with EDS, the ligaments are lax, and the muscles are tight, trying to compensate. And when people keep dislocating a joint, it's because they've got a tight muscle that's overcompensating for something, for a lax ligament, and pulls the joint out of place. Commonly seen in the shoulder, commonly seen in the knee, less commonly but still present in the hip, sometimes in the ankle and foot. So having someone to help relax muscles is really important, and a good physio can help this. Sleeping on a slope. If you're lying flat, your body's got to completely relax. You lie on a slope and your heart's got to do a little bit more work. Small meals often, avoiding that large load of a meal at once. Again, blended foods can make a difference here. Exercise, aerobic exercise, not straining, lightweight, small amounts often, extra fluid when you're doing the exercise, and gentle cool-down exercises are really important. Medication, we're going to have a these main ones covered next. But there are all these which can be quite specific to EDS people, although some of them were mentioned this morning. So people with ADD who are on methylphenidate reduces peripheral blood pooling and actually helps their blood pressure and reduces their POTS and orthostatic hypotension. For females who still have an active uterus, oral contraceptives can make a big difference during the menstruation time. DDAVP, as mentioned before, but it also has this effect of reducing urine output at night. So it can be taken at night time to reduce urine output, so when you get up in the morning, you're not going to go splat. It's also used for people who have spontaneous bleeding as well. Some people with vascular type EDS, Col4A1 can cause microbleeds. Some of the others can also cause spontaneous bleeding and bruising, and this can be a way of reducing that. Pyridostigmine was touched on this morning, and clonidine. Octreotide can also be used subcutaneously to reduce that risk of the blood pooling in the stomach after a meal. Is a zebra white with black stripes or black with white stripes? They actually have black skin and they lack melanocytes in the white areas, so they're black with white stripes. Now the next two slides I've borrowed from James Kustoff, who's very kindly lent them to me, so my thanks to him. Mast cells have corticotropin releasing hormone, and Larry Afrin mentioned CRH in one of his slides this morning. In fact, two of his slides I saw it in. They also release substance P. Now, what I didn't know before is that mast cells produce and secrete corticotropin releasing hormone. I always thought it just came from the hypothalamus until recently. The CRH stimulates ACTH. ACTH stimulates the adrenal glands to produce cortisol and adrenaline. So you've got your first production of adrenaline here from mast cells. Then high CRH levels have been associated with other inflammatory conditions, and it regulates the blood-brain barrier permeability. So CRH is released with acute stress situations, and that in turn stimulates mast cells because mast cells have CRH receptors, and they produce more CRH, and you get this feedback loop. And that affects the brain with the blood-brain barrier, and people get the fuzzy brain, fatigue. CRH also produces vascular endothelial growth factor through the mast cell activation, and that causes a vasodilatory effect as well. So this is just a couple of the areas which were mentioned this morning where you've got this feedback loop causing from mast cells causing more POTS issues. And those were the studies related to that. So what you're seeing, and if this slide pointer works, I don't know if it's going to show up. Is that showing up? No, it's not. You've got the mast cells producing CRH, which feeds back onto the mast cells, which then dilates the blood vessels. You get more fatigue, more cardiovascular dysfunction, more cognitive impairment through the blood-brain barrier effect, more pro-inflammatory effects which then aggravate pain, and the pain also stimulates the production of adrenaline in the pain response pathway. It can be a vicious cycle. So, treating mast cell issues, avoiding triggers, antihistamines, as we mentioned this morning. Larry covered all these in his quick flick through the slides. I'm going to mention sodium chromoglycate, montelukast, and ketotifen because they're readily available and they make a big difference to quality of life in patients. When you get past those, then it's good to have an immunologist involved, and I've borrowed out Larry Afrin's help for a number of my patients, and I have great thanks to him for that. Some unusual effects of POTS in EDS patients. So, children can develop anxiety, obsessive compulsive disorder, tics, pauses, so they'll stop doing something and pause for a few minutes, mood swings, just out of the blue mood swings, and rages, especially when their body's in overdrive, adrenal overdrive. They will struggle to learn and cope at school when these things are active, but when they're inactive, they learn fine. They can have issues of bedwetting later in life, ages of 5, 6, and 7. And often told that they have a functional disorder, like functional neurological disorder, or worse, a factitious disorder. It is not factitious, it's not a functional disorder. So the three cases now, we've got time? Okay. First one, a male aged 8. He was diagnosed a year before these problems came on. He has a genetic type present. And he first developed tics and then started getting obsessive compulsive disorders such as washing his hands very regularly and overwashing his hands. Then he started having swallowing issues, trying to swallow saliva all the time. Then he would have pauses. He'd be walking down the road and pause for 5 minutes, more of concern when he was crossing the road. And then he started developing bladder and bowel incontinence. That's really uncommon in an 8-year-old. He then developed rages. He'd had some insight into those rages and that he didn't know what he was raging at. And his mood improved when he was lying down, but got worse when he was standing. It took a while for the penny to drop. He saw a psychiatrist, and thankfully the psychiatrist, while he didn't know what the answer was, he recognized that it was not a mental illness, and he didn't want it to cause any harm, and he admitted he didn't know what the cause was. He was a fantastic psychiatrist. His pulse was felt when he was having one of these pauses, and it was going at 150, which then led to the right tests for the diagnosis of POTS. He was treated with a beta blocker, and his improvement was almost instantaneous. Within 24 hours, the majority of those symptoms had vanished. The tics, the OCD behavior, the rages, the pauses, they just vanished. The only setbacks he had was when he'd forgotten the medication, and a couple of hours after when he was due to have his medication, he'd be asked, "Had your medication?" "Yep." "No." When he took it, symptoms settled again. He developed symptoms of a urinary tract infection. Male children don't get UTIs unless there's something major going wrong. But in view of the fact that he has had known EDS, he was given a trial of antihistamine. In 20 minutes, the symptoms had switched off. He's now been put onto mast cell stabilizers, and he's doing incredibly well. Second child, a 13-year-old female, when she came to my clinic, she was diagnosed with hypermobile EDS, and she had tics, including profanities, in that first consultation. Parents were really worried about what was happening. She had mood swings, and those mood swings had started before she was getting her periods. Her pulse in the clinic went from 72 sitting to 144 standing. You didn't need to do a lying and standing when you had that dramatic a response from just sitting to standing. She was put onto beta blockade, and again, she had a dramatic turnaround within 24 hours, noted by the family, and the tics stopped instantly. Her mood stabilized, and we haven't needed to see her for a couple of years now. She's done so well. And finally, case 3, a 13-year-old male. He couldn't study at school. He couldn't think straight. He had major brain fog. His speech was a high-pitched, infantile-sounding speech. He could still articulate, but it was this very high-pitched sounding infantile speech. And he reported on occasion having auditory hallucinations. He was told by a neurologist that he had a functional neurological disorder, and that was because he wanted to avoid going to school. He also suffered from chronic migraines. You may think back to this morning's talks to see a relationship here. In the clinic, his pulse went from 72 to 132 from sitting to standing. He also had a joint dysfunction which was found in his neck, and we treated that. And he was started on beta blockade. His speech normalized again within 24 hours. He's back at school. He actually loves studying. He loves his schoolwork. Don't know where this FND came from. And his migraines settled with the combination of the treatments and release of his stuck joints and prototherapy, and that's another talk in itself. Parents were extremely grateful at getting their child back, and this is a common theme that we see. So in conclusion, if you can't connect the issues, think connective tissues. My thanks to the POTS Foundation for inviting me, to my wife and family for their support in this journey of discovery that I've had over the last 8 years, to my patients and their families, including their consent for presenting their cases today, and to the Ehlers-Danlos Society, who have really supported me incredibly along this journey. Alan Hakim, Claire Francomano, Heidi Collins, Larry Afrin, who you saw this morning, Lara Broom, Peter Byers, Fiona Stewart, James Christoph, and many, many more. So thank you very much.